Buenas tardes, good afternoon. Thank you all for being here at this session today, at which we are pleased to have the presence of three distinguished and internationally recognized colleagues, Dr. Bell, Dr. Kastrati, and Dr. Mayer. First up, let me thank all of them for their kindness and generosity in being here. A warm welcome to Malcolm, Adnan, and Johannes. Of course, not nearly as well known as our guests and Dr. De La Torre are, so I'll have to introduce myself. My name is Emad Abu-Assi. I am a clinical cardiologist from Vigo, Spain. Dr. De La Torre, who is an interventional cardiologist at Valdecilla Hospital, Santander, Spain also, and myself are the co-chairs here. The title of the first talk of this session is Anemia Management in Acute Coronary Syndrome, Gaps and Uncertainties. It will be given by Dr. Bell, who is an interventional cardiologist at Mayo Clinic, Rochester. Please go ahead, Malcolm.
Thank you very much. And I'd also just like to give my thanks to the organizing committee for this privilege of being at this international symposium. And I've been here many times before, and just to congratulate you on a wonderful program. This is really world class. I should apologize. I think this is the second time this has happened to me in the last 10 or 12 years in Spain, that my luggage is still in Minneapolis. So I apologize for my attire. But it did give me an opportunity to buy a fashionable European shirt. There are two challenges, though, today. It's a very difficult topic. I think we all think we understand this, and you can see by the title that this is going to be a challenge. But I did not expect another challenge, which was to be the first speaker after Professor Fuster with his brilliant but very emotional lecture. And I would just like to say that Magda Harris was a beloved friend of mine as well. She and I worked together in 1987 at Mayo Clinic, and she and Mark, we've remained very good friends since then. So this is very emotional for me as well, and I hope that it won't interfere too much with my message that I'm going to give here. So I have no conflicts or disclosures, and the topic, as I said, is, I think, a difficult one, gaps in our knowledge about anemia and ACS. But I'll put it to you that it's not a gap at all. It's a chasm. There are so many things we don't know. We don't know the poor prognosis of these patients. Is this by association or is this causal? Is it a simple decision to transfuse such a patient? What sort of strategy should we use? And we're going to talk about this in the next 20 minutes or so. Should we be focused on their symptoms or the hemoglobin concentration? Is there harm with transfusing these patients? And what endpoints should we be looking at? So I thank the organizing committee for giving me such a challenge here to try to fill in some of these gaps. So one of the things we're going to be talking about is blood transfusions. And it's interesting when you look at this literature, you find that there's only a few names of authors and researchers who've really studied this, and two in particular, and you'll see those names as I progress. But just to put this in perspective, worldwide, about 85 million units of blood are transfused annually, about 15 million of these in the United States. And it's also interesting as we think about transfusions, because we can't talk about anemia and ACS without talking about transfusions. The Institute of Medicine estimates that $765 billion a year are wasted in the United States healthcare system. And about 200 billion of those are on unnecessary services. And so this prompted the American Medical Association and JCO to have a national summit on overuse, and they identified 5 medical therapies that they felt were being overutilized. And they really focused on these. And you can see, just to put a perspective, ear tubes. Well, fortunately, I don't have to talk about ear tubes today, but you can see coronary stents and transfusions are among these. And just a few words to just put this again in perspective. These are just some general guidelines about transfusion strategies. And we're not talking about patients with coronary disease. These are all patients. And just to make the point that we've gone beyond that 10 grams, 30% hematocrit that many of us learned when we were in medical school and in residency as an indication for a transfusion. But today it's generally preferred that we follow a restrictive rather than a liberal transfusion strategy. And by that I mean a restrictive lowering the hemoglobin concentration which would trigger a transfusion. And that's generally recognized to be about 7 to 8 grams per deciliter. But also to take into account patients' symptoms and also patients' wishes. On this slide, I've just summarized the findings. These are from 19 randomized clinical trials of restrictive versus liberal transfusion strategies. And it includes the 2 largest ones, which I'm not going to have time to go into, but many of you will be aware of the TRIC trial back in 1999, an intensive care study, about 800 patients, and the more recently published study, the FOCUS trial, which is about 2,000 patients. But those are the 2 largest ones. Most of these are relatively small studies, but we're talking about randomized trials. So it obviously decreases the probability that a patient will receive a transfusion, fewer units are transfused, a trend, but not significant, towards lower 30-day mortality with a restrictive policy, but no increase in MI risk, no difference in the length of stay or functional recovery, and that's important when we think about what other endpoints we might be interested in. And interestingly, it does appear to decrease the serious but not overall infection rate. Another way to look at this, though, is to say that there may be no difference in outcome between a liberal and a restrictive, so no harm in a restrictive approach, but also no harm in a liberal strategy. And so in the last few years, I suspect that this has been happening in Europe, certainly in a number of institutions in the United States, including our own. They're trying to standardize blood transfusion strategies and to make them more restrictive. So at our own institution in 2013, our blood bank group circulated the guidelines. These were part of the electronic ordering system in 2013, and we saw and I'm not going to go into the details of what the criteria were, but they were in line with the published guidelines. But it's interesting, even at Mayo Clinic, in 2013, 40% of transfusions were given outside of published guidelines. But despite this effort, over 2 years, we did decrease that to 25%, but you can see the challenge here. 25% of transfusions were still considered to be outside of the published guidelines. I can't really comment whether they were appropriate or not appropriate, but that's an important thing to notice. The other interesting thing is that in our own, just our single institution, this resulted in a cost saving of more than $11 million instituting this strategy. So let's talk about patients with coronary heart disease, and the question here is, are they at greater risk of anemia? Well, I think there's probably no doubt that they are. If we think about just the physiology of this, actually most normal people can tolerate significant reductions in their hemoglobin, maybe down to 4 or 5 grams per deciliter, because they could potentially tolerate that because of compensatory mechanisms. But in general, when the hemoglobin concentration starts to decrease significantly, our heart rate goes up, there's a little bit of afterload reduction, so our cardiac output goes up to compensate. On the other hand, if we have coronary artery disease, obstructive disease, and remembering the myocardium has a very high oxygen extraction ratio, and that can only increase with higher flow. So if we do have significant obstruction, this is when ischemia may occur in the setting of very severe anemia, and ultimately may result in decrease in cardiac function. So if we look at this in the clinical arena, this is a study, the details are not really that important. This is a randomized trial of some various antithrombotic regimens. But if we look at this ACS population, looking at ischemia in anemic patients, you can see here that patients in the first 48 hours who were anemic with a hemoglobin of less than 12, they had very high prevalence of recurrent ischemia in the first 48 hours, and you can see here that diminishes the higher the hemoglobin concentration is. Now, what about patients who have cardiovascular disease and undergo non-cardiac surgery? This is a really fascinating study. This was a study of about 2,000 patients who had undergone non-cardiac surgery but had refused blood transfusions for religious reasons. And so in many ways, this is like a natural history study because we're not going to transfuse these patients. And you can see here that the lowest hemoglobins were associated with the highest mortality, and that diminished as the hemoglobin concentration increased. And furthermore, you can see significant morbidity and mortality, and this was patients with MI and infections and respiratory problems here. About 25% of the patients in that study did have cardiovascular disease, and you can see that almost all of the mortality was really attributable to the group who had cardiovascular disease. What about the ACS patients? How often do we see anemia or bleeding? And this is just really an overview here of a number of important randomized ACS trials. And you can see here that the risk of major bleeding ranges from about 2% to about 10%. The problem here is that all the definitions are very, very different. And that's been a problem when comparing one study or one strategy or one drug to another. So it's very important that in 2016 that we really focus on using a universal definition, and currently that's probably the BARC classification of bleeding. But and again, it depends on the population being studied, and these are selected patients because these are patients who actually got into a randomized trial. But from observational studies, about 20 to maybe even 30% or so of patients may actually have baseline anemia when they present with ACS. So this really is a common and important problem. So from these observational studies, you can see that the patients who are at the highest risk of bleeding are listed here. And I think almost all of you are going to be familiar with these. And it's the older patient, women, lower body weight, some of the drugs that we use, particularly 2B3A inhibitors, femoral rather than radial access. And one thing which we often forget about, which is very important, we'll come back to this later, is chronic kidney disease. And so there have been multiple observational studies, dozens and dozens, have clearly shown a link between patients who have anemia or bleeding in the setting of ACS with subsequent early mortality and perhaps also long-term mortality. These, of course, as I said, are observational. It doesn't prove causality. And again, it depends on the definition used. So, for example, we're very familiar with the TIMI classification of bleeding. And yet, when it's been studied using the TIMI classification, the link between bleeding and mortality is not so strong. You use the Gusto definition, which is a more clinical classification system, and it's a very strong correlation. So again, just making the point that when we study this and talk about this, that we're really using the appropriate definitions. Bleeding is important though. And let me just walk you through 2 or 3 slides here. These are really fascinating. As I said here, bleeding with respect to mortality is just as important as if you'd had another MI. So remember, these patients have presented with ACS. And you can see here the hazard ratio for mortality for bleeding and transfusion is about the same as if the patient had had another MI. And if we look at this in more detail, these again are data from Acuity. When is the worst time to bleed? Well, if we look at MI, again here you can see the hazard ratios for mortality. They're high, but they gradually decrease over the first 30 days, and you can see it's lowest after the first month. On the other hand, major bleeding, really doesn't matter when you bleed early on, is associated with a very strong mortality hazard. And it's still there even after a month, but less so. And you can see here that transfusion really just follows, it mirrors what we see with bleeding. And just to point out here that the timing here, if you look down here in the bottom left-hand corner looking at major bleeds, most of the major bleeds occur in the first 7 days. And so one question I'll ask you is, if you're thinking about, for example, triple therapy, currently the European consensus document is you give aspirin for the first 30 days and then stop it, but where's the data to support that? Most of the serious bleeding occurs in the first month. And in Acuity, you can see here in the first 7 days. So what we do with the patient in hospital, what we dismiss them on medication-wise for the next few weeks is really critical. What about transfusions? Again, a number of studies looking at this showing that patients who are transfused in the setting of ACS have a higher mortality than those patients who weren't transfused. So here's an obvious question. Do transfusions kill our patients? Well, I tell you that some people think that transfusions are harmful and that they may well contribute to the mortality of a patient. But I think it's very, very important to remember these all come from observational data, and all of these studies suffer from one serious flaw, and that is that the sickest patients are the ones who are most likely going to need a transfusion, and of course the sickest patients have the highest mortality. So very, very important to remember that. On the other hand, we know that transfusions can be harmful. And the safest transfusion to give is the one that you don't give. And so the question here is, should we be transfusing our patients? And if so, should we expect harm from that or benefit? And just to put this in perspective, currently 2016, transfusions have probably never been safer. We're all concerned about the risk of infection transmission, particularly HIV and hepatitis C. But you can see here that the highest risks are actually no more than 1 in 100, and this is with TACO, which is transfusion-associated circulatory overload, or a fever. And then right there in the middle is TRALI, which is transfusion-related acute lung injury. And this is the most serious, but it's very uncommon, particularly today. I've seen a few cases of these over the years, but it is associated with a significant mortality, so it's one that you want to avoid. But just putting that in perspective, you can see in the rose-colored boxes here what the mortality is with motor vehicle accidents and from having a fall. So the risks are there, but they're very, very small in terms of having harm from a transfusion in itself. So if a patient bleeds or is anemic, why would that lead to higher mortality? And I think as you look at what I've listed here, most of these I think are fairly obvious. There's the physiological stress that we talked about with recurrent ischemia, which potentially could lead to lethal arrhythmias. Clearly shown that these patients are less likely to receive aspirin because they're bleeding, and so it may be a patient who's also anemic and aspirin is withheld. But in your own practice, you can think about patients who are bleeding, and what's one of the first things you're going to ask yourself, or you are asked by someone else? Should we stop the aspirin? Should we stop the ticagrelor or clopidogrel? Should we stop the heparin? And often it is stopped, or those are stopped. If the patient is really sick, we might even then stop the beta blocker. We may stop the statin just because the patient is so ill. So there are many things that go into this. The patient may be hypotensive. The patient may actually have underlying malignancy, and this is not uncommon, particularly in the older patient. And so now they're starting to bleed, and suddenly we realize they've got a lung tumor or a bladder tumor or some other malignancy. We've talked about the transfusion risk already. But I think it's very clear from these studies that it is almost certainly related to association, so the sicker patient having these problems, than causality. In terms of transfusion risk, I mentioned earlier that the restrictive approach didn't seem to be associated with a lower mortality or higher mortality. So no study has ever really shown that a liberal transfusion strategy leads to higher mortality. So as you look at these studies, it's difficult to say that transfusion will actually be directly responsible for mortality. And I hope I'm making that clear enough. And in fact, in studies that you've looked at patients, did they receive 1 unit of blood, or 2, or 4, or 5? No difference in outcome, no difference in mortality, and that's in a general population. So I think there's very little evidence to suggest that transfusions are in of themselves harmful and particularly related to higher mortality. When we're not quite sure what to do with our patients, we go to the guidelines, don't we? And certainly on our CCU rounds, we worship at the temple of guidelines every day. But if we look at the American College of Cardiology guidelines for when we should transfuse in ACS patients, the only thing that they tell us is don't transfuse if the hemoglobin is more than 8. This is a class 3 recommendation. They don't tell us when to transfuse, they just tell us when not to transfuse. The European guidelines are a little bit more helpful. You can see here, transfuse if the patient is unstable or if the hemoglobin is less than 7. But that's only a 2B recommendation. And the American Association for Blood Banks, they make no recommendation at all. And in fact, it's interesting to go and look at those a little bit more carefully. So the American Association for Blood Banks, or AABB as it's now called, looked at making guidelines based purely on randomized clinical trials. Didn't want to look at observational data. Everyone understood that the observational data can be quite difficult to interpret. And so in hospitalized patients, those who have pre-existing cardiovascular disease and who are stable, a restrictive strategy, as you can see, is recommended. And you can see what the quality of the evidence is. It's not too bad. But these are in stable patients. When they looked at ACS patients who are hemodynamically stable, they couldn't make any recommendation. And they made this point because they said the quality of the evidence was so low, there was nothing they really could recommend on this. And I can tell you, just getting back to the transfusion and bleeding data from the observational data, we published a study many years ago looking at this and showed the link between anemia and subsequent mortality in about 17,000 patients. We just presented updated data at ACC last week. And I'm not going to show you that, except that just to point out that when you look at the baseline characteristics of the patients who were anemic versus the patients who were not anemic, the p-values were all less than 0.001 for every characteristic, and they're just the ones that we measured. So I don't think that any amount of multivariate analysis, adjustment, propensity models are going to correct for that. And I can tell you, just getting back to the transfusion and bleeding data, we published a study many years ago looking at this and showed the link between anemia and subsequent mortality in about 17,000 patients. We just presented updated data at ACC last week. And I'm not going to show you that, except that just to point out that when you look at the baseline characteristics of the patients who were anemic versus the patients who were not anemic, the p-values were all less than 0.001 for every characteristic, and they're just the ones that we measured. So I don't think that any amount of multivariate analysis, adjustment, propensity models are going to correct for that. And so what do we do? Well, the only thing we can really do at the moment is we've got to prevent bleeding in these patients. We've got to assess the bleeding risk of our patients. I'll come back to that in a moment. We've got to select the appropriate medications, particularly the anticoagulant, antithrombotic medicines. And whether or not we believe in using an agent such as bivalirudin, which is very expensive, we generally do not use that. But it's very important that no matter what you're giving, make sure that it's appropriate for that patient, and we dose adjust, particularly for age, kidney function. Avoid triple therapy if you can. Use a proton pump inhibitor if they have an increased risk of bleeding, particularly in the elderly, and think about vascular access. And a few words just on antithrombotic dosing errors. These are not uncommon. And in one large study from the Crusade Registry in the United States, up to 33% of patients received at least one wrong dose of their medication. And we're talking about antithrombotic agents, the various heparins, could be fondaparinux, 2B3 inhibitors, etc. Okay. And interestingly, the risk of having the wrong dose was highest in the very patient you wouldn't want to make that mistake in. And these are the most vulnerable patients. These are the ones who are more likely to bleed, as you can see from this list. These were the ones who got the wrong dose. So we really have to work very hard at that. And either this is because as clinicians, we don't have the awareness that that patient is at high risk, or we choose to ignore it for whatever reason or convenience. Very, very important. I'll say a few words about the radial access. I mentioned this earlier. Here's a meta-analysis of STEMI trials, so primary PCI. You can see here a significant reduction in bleeding with the radial versus the femoral. And again, you see this association. You have less bleeding, you're going to have decreased mortality. But look at this. The number needed to treat to save one life with a radial approach is just 50 patients. And I will put it to you, if this were a drug, you would have people knocking at your door every day asking you to prescribe this drug. And in Europe, you've led the way in this. A number of Asian countries. We've lagged behind, though, in the United States. It's actually improving and increasing use of the radial approach. And furthermore, your guidelines have just come out. I'm sure you're aware of this. The 2015 ACS guidelines clearly indicate it's now a class 1 recommendation to do a radial approach in these patients rather than a femoral approach. And then just as I'm finishing here, this is also a very interesting study. It gets back to a point I made a bit earlier about identifying patients who are at higher risk. These are NCDR data showing the radial combined with bivalirudin decreased the risk of bleeding significantly compared to femoral treated patients, even if they got bivalirudin or closure devices. But more importantly, the patients, again, at highest risk of bleeding were the patients least likely to receive bivalirudin, or more importantly, I believe, have a radial approach. So I think there's something that we are lacking here in terms of care of our patients. And one final point, aspirin. How strongly do we believe that aspirin is critical for secondary prevention? Already, we've stopped using it generally for primary prevention. And everyone, we know, we say, the patient's got to be on aspirin. They had an MI, they had a stent. But they're also on a P2Y12 inhibitor. Where are the data to show that dual antiplatelet therapy is better than monotherapy with a P2Y12 inhibitor? Just food for thought here. And the study's never been done as far as I'm aware. Wouldn't life be so much simpler if we weren't using aspirin in all of our patients? We generally accept that we've got to give aspirin, just like we used to accept that bleeding was just part of the treatment of ACS. But when we see this link between bleeding and anemia with mortality, we need to think twice. We no longer accept this as being something that we'll accept because we're reducing the chance of an MI. So I just throw that there just to be a little provocative. So in summary, Anemia in these patients is relatively common, and as I've pointed out, has important prognosis with respect to mortality. Is it by association or is it causal? It's very clear when you go and look at the literature very carefully that the quality of the data to guide the management of these patients is really lacking and is poor. And it's important because transfusions, they're a precious resource, they're expensive, and we've got to be careful, in our utilization of this. We probably should be using a restrictive approach here, but combined with clinical judgment. Is it a hemoglobin trigger here, or is it on symptoms? And we should do a much better job of identifying these higher risk patients. And then finally, what can we do with research in the future? As Sunil Rao, in his recent editorial, pointed out that we have the opportunity here to use novel statistical approaches to these large observational databases. I was actually thinking this last night when Dr. Krumholtz talked about precision medicine. We have an opportunity there as well. But there are so many confounders. We've got to minimize those so we can really learn the truth here. And we're desperately in need of randomized clinical trials. Can we maybe take the approach that was used in the TASTE and the SAFE PCI trials, registry-based? What's the appropriate transfusion trigger? A particular hemoglobin or symptoms? See, even liberal versus restrictive, these hemoglobin levels are quite arbitrary. We should probably have a usual care arm in this, and which patients are going to be benefit from transfusions and which ones might be harmed. And so here I think this really summarizes where we're at and why we've got this gap. As I mentioned, these are the two prominent researchers in this group, and in a recent editorial say that given the real risks and potential benefits exist as to how we choose this valuable resource of blood transfusion, they believe that high-quality research in this field is long overdue. So there's my email address. You can contact me if you have any questions, want to follow up with anything, any suggestions. But otherwise, again, I thank you for the opportunity to be here, and thank you so much for your attention.
Thank you very much, Malcolm, for having gone through this interesting and complex topic. Does anyone wish to? We have no time, so we should move on to the.
I have one.
Okay.
There's only one comment, Malcolm. Congratulations for the presentation because it's really comprehensive. It's clear that we have two kinds of anemia. It's anemia that the patient is carrying on just at the moment of the ACS, and maybe it's a trigger for the ACS. And this anemia many times is not bleeding related. Maybe it's less related with bleeding. And secondly, we have the anemia that is developed after your ICS because you are on drugs that aren't thrombotic. And I miss in all this analysis differentiation between both anemia because maybe it has implications in prognosis, in treatment, in threshold for transfusion because this anemia, both types of anemia have a very different relation with the ACS and maybe deserves a different approach. No?
It's a really good question, and the brief response here is that in most of the studies, they have really not separated these out. So if you look at studies of anemia, you're struggling to work out, was it pre-existing or did it develop when they were in hospital? And the reality is that you see all types. So you see people who have anemia, but as I pointed out, patients who have baseline anemia are more likely to bleed. So that's very, very clear. But I do think that when you look at the very few studies that have, and I showed some of them there just with those earlier studies, they actually do have a worse prognosis. If you bleed, even if you started off with a normal hemoglobin, that's a worse prognosis. And in many of these, it's combined. But I would agree, in looking at the studies, it hasn't always been clearly differentiated. You look at the methodology of these studies, it's really not clear.
Oh, we're going to move to the second lecture because we have some delay. Dr. Kastrati. Dr. Kastrati is very well known among all the cardiologist community because who among these people today, the audience, don't know is our trial. No? Dr. Kastrati is from Munich, Germany, and he's director of the Cardiovascular Disease Program and Catheterization Laboratory. And last but not least is the director of the ISAR research program with many trials in the last 20, 25 years. And they have maybe approached every single relevant problem in acute coronary disease with the ISAR trials, from antithrombotic treatment to restenosis and to interventional issues or acute cardiac care. Then I think it's an honor for us to have Adnan Kastrati and the ISAR group here. He's going to approach the topic of maybe the new recommendations of guidelines regarding the time to do the angiography in relation with the risks of the patients, and then maybe the need of networks or systems to provide these PCIs or angiographies in a very short term. Thank you.
Thank you very much, Jose, for the nice introduction, and I thank also the organizers for the invitation to be here. It's for me the first time to be here, but I immediately realized that it was a big mistake not to have been before here. So, first of all, I would like to show my conflict of interest here with regard with the topic here. In Munich, there is no network at all for patients with non-SS segment elevation acute coronary syndromes. Even for STEMI patients, there is no formal network strategy. And there are a lot of catheterization laboratories there, many centers in every angle of the city. And I have the impression that the patients don't go to the center, are physicians from the centers waiting outside for the patient. So it's an area in which it's a big competition, and I don't think that there are delays in Munich for treating patients with acute coronary syndromes. So what is the rationale and feasibility of an acute coronary syndrome network? To build such a network, there should be a need for a perfusion, revascularization in a prompt way, and also the prompt diagnosis should be feasible in the large majority of patients. Let's look at the typical findings in patients presenting with a provisional diagnosis of acute coronary syndromes. And you see that there are certain signs that make us think about this diagnosis. It's the clinical presentation, the symptoms, ECG, the troponin test, and at the end, you have different possibilities to categorize patients with acute coronary syndromes, but the easiest categorization is ST segment elevation myocardial infarction, because for that, you need the symptoms and you need the ST segment elevation only. So, but is there a need for a perfusion revascularization in a prompt way in patients with STEMI, just to justify the need for STEMI networks? You know the old meta-analysis of all fibrinolysis trials, and here are shown all of them. The number of patients is huge, it's about 60,000 patients who were randomized between fibrinolytic therapy and control therapy. And you see that there is a significant reduction in mortality. It's 18% reduction in mortality through the use of fibrinolysis. But the reduction in mortality is even higher if instead of thrombolysis you use primary PCI as a reperfusion strategy. You see here, it's a PCI-T2 individual patient data analysis published 2006 in the European Heart Journal, and all the trials that compared primary PCI to fibrinolysis, overall, you had a 37% reduction in mortality, and you see that this was not dependent on the time between presentation and performance of reperfusion strategy. So reperfusion strategy is very, very important in patients with STEMI, but should be prompt, and there are many data showing that mortality is dependent on the door-to-balloon times. That means that the shorter the door-to-balloon times, the better the reduction in mortality in patients with STEMI. And you see here 3 curves showing that all in-hospital mortality, 30-day mortality, 1-year mortality are increasing with the increase of the door-to-balloon times. Now, is prompt diagnosis feasible in the large majority of patients with STEMI? As I showed before another figure for that, here it's much clearer that patients with persistent SS segment elevation, they don't need to have a biomarker test to establish the diagnosis of STEMI. On the other way, non-STEMI unstable angina patients, to have this diagnosis, need also the confirmation by biomarker tests. Let's look at this data set of 820 patients presenting with the initial diagnosis of STEMI with SS segment elevation. And you see that in only 2.3% of them, there was, at the end of the hospital stay, no final diagnosis of STEMI. So you really make a very small mistake by being based on SS segment elevation in symptomatic patients suggesting SS segment elevation myocardial infarction. Now, there are certain delays for the treatment of patients with STEMI. It's the patient delay, which is less influenceable by us because it depends from the patient when it presents with the symptoms at the hospital or at the emergency medical system. But there is a system delay, which is very important to be shorter in order to provide these patients with a prompt reperfusion strategy. And according to guidelines, it's possible and it should be achieved less than 10-minute interval between the first medical contact and the diagnosis of SS segment elevation myocardial infarction on the basis of electrocardiogram. So I show this complex table here just to highlight that the guidelines of STEMI therapy give a lot of importance to the regional networks in the treatment of patients with SS segment elevation myocardial infarction. So this is the scheme, how we deal with patients with STEMI. If the patients are presenting directly to a primary PCI capable center, then primary PCI is performed there. If they are presenting in other, without a cath lab and without the possibility to perform a PCI, then the question is a PCI possible by transfer within 120 minutes? Yes, the patients are transferred. If no, then it is possible to thrombolyze these patients and then to send them for control angiography. So for this, there are very well-established protocols for networks for patients with STEMI. They have a clear definition of geographical areas of responsibility. They have also shared protocol and transportation by trained paramedical staff. Also, pre-hospital triage of STEMI patients to the appropriate institutions, bypassing non-PCI hospital whenever primary PCI can be implemented. Also, these patients should bypass the emergency department and go directly to the cath lab. This is all what is done in STEMI networks. Although these networks are very well established, the guidelines are very strong for that, you see the distribution of the reperfusion of the proportion of the patients with STEMI to be reperfused throughout Europe here. And you see that there are areas in which only less than 10% of the patients with STEMI are not reperfused, but there are also areas in which more than 60% of the patients with STEMI are not reperfused. Below here, you show this map here for the proportion of patients with reperfusion therapy that get primary PCI. And you see that the darker area have a higher proportion of patients getting PCI as a reperfusion strategies, and brighter areas, and Spain, the sunny country is brighter here. It shows that the proportion of patients getting primary PCI is not that high, but I hope that between 2009 and now, the proportion is increased for sure. Let's look at the rationality and feasibility of a non-ST segment acute coronary syndrome network. And for this, we should put a little bit more questions. Is a need for revascularization in patients with non-ST segment elevation acute coronary syndromes. Here is a meta-analysis of 7 randomized trials with more than 9,000 patients. And the endpoint analysis is meta-analysis is death or myocardial infarction. You see that there is a reduction, but it's not clearly significant here. And if you look at more detailed analysis, you see that the reduction in mortality here is dependent on the number or on the proportion of patients with ST segment depression. That means that the high-risk characteristics of SEG provide a PCI with more chances to reduce mortality in patients with acute coronary syndrome. That means that patients with acute coronary syndromes are not a homogeneous subset that benefit all the same reduction in mortality by PCI. Let's look at data showing a longer follow-up. 5-year follow-up is published by 3 randomized clinical trials, and you see here that there is a reduction in the combined endpoint of cardiovascular death or myocardial infarction. Here you see that it's a 19% reduction in that, and for cardiovascular death is also a reduction of 70%, which doesn't reach the significance level. But you have also to consider that even the patients that were randomized to selective invasive therapy, they get over the time a lot of them get PCI. That means that there is not a clean comparison between no PCI and PCI in patients with acute coronary syndromes. It's very interesting data published last year showing that Courage study has had a very large impact on the number of PCI done in stable patients, but no impact at all in the number of procedures done in acute coronary syndromes, because the evidence is strong for the benefit of PCI in these patients. Is there any additional room to improve the results in these patients? Malcolm said that radial approach is being associated with clinical benefit, and here are the results of the most recent trial, the Matrix trial, showing a reduction in all-cause mortality. Here it's a 28% reduction through the radial access as compared to the femoral access. Myocardial infarction was not significantly impacted. Stroke also. On the other side, you see that the bleeding rates were significantly decreased, and this might be the reason why mortality was reduced by the radial approach in the Matrix trial. Now, how important is a prompt antiplatelet pretreatment, which makes also more necessary a network in patients with acute coronary syndrome without ST segment elevation? There is only one trial looking exactly at this point for patients with non-ST segment elevation acute myocardial infarction, the ACOS trial, which was stopped prematurely because there was no benefit in the primary endpoint of cardiovascular death, myocardial infarction, stroke, and urgent target vessel revascularization. On the other side, there was an increase in TIMI major bleeding. This trial was done with prasugrel. We don't have similar data for ticagrelor, but based on this data, the task force writing the guidelines for non-ST segment elevation acute coronary syndrome didn't mention the need for pretreatment in the most recent European guidelines. How prompt should revascularization be in patients with non-ST segment elevation acute myocardial infarction? We have one trial looking at this aspect, the TMAX trial, which compared early with a delayed strategy in patients with acute coronary syndromes. There was no significant reduction in the primary outcome, which was a combination of death, myocardial infarction, and stroke. There was a significant reduction in death, myocardial infarction, and refractory ischemia. But when the authors looked at the gray score, that means what was the benefit according to the risk score, to the GRACE risk score in patients with non-ST segment elevation acute coronary syndrome from a prompt strategy as compared to a delay strategy, you see the difference. Patients with a low GRACE score, with a low risk of acute coronary syndromes, didn't benefit from doing earlier the intervention. On the other hand, patients with a high risk score, 140 and above, they had a large benefit, 35% reduction for events through a prompt strategy. And that's why GRACE score is used very frequently in our management of patients with acute coronary syndrome. And also the most recent guidelines, they give a class 1B recommendation for the use of risk scores for prognosis estimations in patients with non-ST segment elevation acute coronary syndromes. So there are a lot of criteria used for the categorization of patients in risk categories. Very high risk criteria, they include hemodynamic instability or cardiogenic shock is the most frequent presentation, recurrent or ongoing chest pain. Also, there are arrhythmias, cardiac arrest, etc. And these very high-risk patients should receive invasive strategy within 2 hours, and they get a class 1 indication for this recommendation. High-risk criteria are other criteria, less high risk than the first group, and in this case, the patients should receive invasive strategy, but it might be done within 24 hours and not 2 hours as the first category. Other patients with intermediate risk, they can receive the invasive strategy within 3 days. Low risk, very low risk patients, they don't need invasive strategy. They should be tested by non-invasive means, and they get also for this a class 1 indication. But the number of patients, the proportion of patients with very high risk criteria is very low, less than 10%. There are also other risk criteria that are evident first in the cath lab. For example, here there is a study looking at the OCT image of patients with acute coronary syndromes, and those patients who had thrombus on a ruptured plaque, they had much worse clinical outcomes as compared to patients in whom the thrombus was situated on an intact fibrous cap. But this cannot be done before sending the patients to the cath lab. Is prompt diagnosis feasible in the large majority of patients with non-ST segment elevation acute coronary syndromes? Again, back to the picture here. So you need symptoms, you look for ECG changes. You also search for troponin elevation in these patients in order to separate patients with non-STEMI from those with unstable angina who has no elevation in biomarkers. This is a very interesting, small study, but very interesting from the design. 216 patients with provisional diagnosis of non-ST segment elevation acute coronary syndromes. They were seen at the admission with ECG, troponin, and other laboratory parameters. They had a second ECG and second troponin measurement. They had coronary angiography and other examination. At the end, independent investigators, they established the diagnosis of acute non-ST segment acute coronary syndrome or excluded it. And you see the division here. 162 patients from this group had non-ST segment elevation acute coronary syndrome on the basis of the evaluation from the review board, and 54 patients were discharged without this diagnosis. They looked at the value of initial ECG and initial elevated troponin in this population, and you see that initial ECG had a sensitivity of only 28%. The specificity was not bad, 78%. If you look at troponin, sensitivity was a little bit higher, 34%, with a very high specificity, 98%, but having a negative troponin test at the beginning doesn't exclude that the patient had a non-ST segment elevation acute coronary syndrome. So it is recommended to base the diagnosis on the basis of the most recent guidelines from the ESC, initial short-term ischemic and bleeding risk classification on a combination of clinical history, symptoms, vital signs, other physical findings, ECG, and laboratory results. That means it's a very complex process to establish the diagnosis because it's a combination of many factors that are not available from the beginning. It is recommended to measure cardiac troponins with sensitive or high sensitive assays and obtain the results within 60 minutes. There are very established protocols for 0 and 3 hours. It means that you do a troponin measurement at the beginning and you repeat, if negative, after 3 hours. But there are also emerging new protocols, very faster protocols within 1 hour. For this case, the troponin test should be also established. Not every troponin test is good for being based on this protocol. But let's look where the patients with acute coronary syndromes present, and this is a study done in the Netherlands, 202 patients. Most of them were presented with symptoms of acute coronary syndromes in the praxis, in the general practitioner, and some of them were presented directly to the CCU, very few of them to the emergency department, and you see the path of all these patients that at the end, they ended at the CCU. If you look at the time intervals, those who took the ambulance directly, they had a very short time interval between symptom onset and presentation. The others had much larger, much greater intervals. At the end, the recommendations are also for these patients based on the category of the risk category of patients with non-ST segment elevation acute coronary syndromes, and the immediate transfer to PCI center is only recommended for very high-risk patients. So let's look back at the rationale and feasibility of a non-ST segment elevation acute coronary syndrome network. We put the question, is a need for revascularization? Yes, in the majority of patients with acute coronary syndrome. Should revascularization be prompt? Only in a small proportion of patients, because the very high-risk patients are a small proportion of patients with non-ST segment elevation acute coronary syndromes. Is a prompt diagnosis feasible? And I believe that I have shown to you that only in a small proportion of patients you can establish the diagnosis from the beginning, from the presentation. So just to answer the question, has the time come for non-ST segment acute coronary syndromes networks on the basis of current diagnostic and treatment guidelines of patients with non-ST segment elevation acute coronary syndromes, building special and cost-effective non-ST segment elevation acute coronary syndromes networks does not seem to be feasible. Existing STEMI networks are often used for very high-risk patients with this pathology, for example, cardiogenic shock patients, cardiac arrest patients, life-threatening arrhythmias, etc. However, we have a lot of tasks to achieve. Increase patient awareness about the symptoms of acute coronary syndromes and seeking appropriate medical help, because many patients, they cannot differentiate between symptoms of acute coronary syndromes and other symptoms. Increase familiarity of emergency medical systems with risk stratification protocols, because I have shown to you that these are very important to to send the patient to the right center. Improve ECG training of emergency medical system. And very important for me is also to increase telemedicine coverage for prompt transfer, not only of ECG data, but also of other patient data to specialized centers in order to establish quickly the diagnosis. And I would say the increase in availability of point-of-care troponin tests helps also a fast diagnosis in these patients. Thank you very much for your attention.
Questions, comments, guesses? Okay, Dr. Barrabés.
Thank you for your presentation. My question is regarding the second group of risk classification by the ESC guidelines, the patients at high risk who compose a big proportion of ACS patients, because there are, in fact, most patients with confirmed acute coronary syndromes. If a patient arrives with a normal ECG and normal troponin, it's a patient to study, to evaluate. And current guidelines recommend same-day coronary angiography and revascularization in these patients. Do you think that the strength of current evidence supports this quite aggressive strategy?
Yeah, for sure. I am for an invasive strategy in all patients with acute coronary syndrome, for sure. The problem is how can a network for this patient help to achieve this strategy very quickly. So if you give 24 hours, I think that there is no need to have an expensive network to achieve this, because it is achievable also without this. And that's why if you look at the guidelines, there is no mention at all of a need for network for patients with non-ST segment elevation acute coronary syndrome. It's very good to have it, but it's too expensive, and the cost effectiveness is very low.
So we have no enough time, so we have to move to the next lecture, which will be given by Dr. Jans Meyer. The title is A Look Beyond Myocardial Injury, What is New on Biomarkers for Diagnosis and Risk Stratification of ECS.
Thank you very much for the introduction. And first of all, I want to thank the working group on ischemic heart disease and acute cardiovascular care of the Spanish Cardiological Society for the invitation and the hospitality, which I really appreciate. So the topic of the day, I will look on biomarkers. First of all, I will focus on what has already been achieved during the last 2 decades, and then I want to try to give a look on the future. So here are my disclosures on this topic. And let's start with the standard biomarkers we use in chest pain patients or in patients with suspected acute coronary syndromes if they present to the emergency department. First of all, of course, we want to rule out infections. We use the blood count, we measure CRP. Usually, you should be aware that nowadays these assays used in the central labs combine the features of the standard and the high sensitivity C-reactive protein assays. So actually the result, what you get is a high sensitivity C-reactive protein test result. And you should be also aware of the fact that these standard markers we use, such as the neutrophil count and CRP and fibrinogen and so on, they are established markers for risk stratification in acute coronary syndrome patients and also in patients with chest pain presenting to the emergency department. So we already have very well established markers. Then more recently, another inflammatory marker, procalcitonin, has been proposed. This in some respect has advantages over C-reactive protein. In others, there are also flaws, so it's not generally accepted yet. On the other hand, we have the dimer, which is also an established marker and also included in the guidelines, and it's an established marker for ruling out pulmonary embolism in the low and intermediate risk population. We also have emerging data that this marker might be also helpful for ruling out acute aortic dissection also in the low and intermediate risk population. And then we have the natriuretic peptides. They are very, very helpful for ruling out acute heart failure in the emergency department, and in particular for decreasing the need for acute echocardiograms done in the emergency department. And then we come to the topic of the talk with the troponins. As you know, they are now the gold standard. And with the implementation of high-sensitivity troponin testing in routine, it's also possible to implement new accelerated diagnostic pathways, which have already been mentioned. You already have seen this picture, and what has been observed during recent years with each new assay generation of troponin assays with an increased analytical sensitivity, the proportion of patients diagnosed as an unstable angina has been decreased and the numbers of non-STEMIs has been increased, just because we are able to detect smaller amounts of myocardial injury in this patient population. So unmet clinical needs have already been covered by the previous lecture. Still, we have sometimes problems as we get patients which are not primarily seen in a primary BCI center too late because not every occluded coronary artery presents with ST segment elevations. And the other important issue which already has been covered is we frequently would also like to see the high-risk non-STEMIs earlier than we do in our standard practice. So, and also in this respect, these new accelerated diagnostic pathways, not only the focus on ruling out, but also the focus on ruling in the working diagnosis of acute coronary syndrome is helpful. So I would prefer ruling in the working diagnosis because, as you know, the discharge diagnosis may be very different in a lot of patients sent as so-called non-STEMIs to the CAS lab. But anyway, if you are going to implement such a 0-1 hour protocol, which is supported in the guidelines, you have to be aware that you can only do this with two assays. Only two assays on the market fulfill the guidelines of a high sensitivity assay. This is the troponin D assay from Roche and the troponin I assay from Abbott. All the other assays are not suitable for this kind of protocols. So first of all, if you go home, you have to check with your lab director which assay, particularly which troponin I assay he uses, before you are going to use such a protocol. Here you see these absolute changes recommended in the guidelines, so I do not want to go into detail. Another thing which should be in your mind that, of course, you can rule out acute myocardial injury with a high sensitivity troponin assay if you look on the kinetics, but what you cannot do is to rule out coronary artery disease, because as long as the blood supply is sufficient to prevent necrosis, troponins won't increase, at least with the current assay generations we have in the lab right now. Eventually, however, this may change because you may be aware that in the meantime also so-called ultrasensitive assays for troponin I are available, and with these assays you can measure troponin I almost in every patient and in every healthy individual. And of course, this also makes problems in daily routine, but which could be shown is from the TIMI study group, they used their biobank and looked on this troponin concentrations before, during, and after the hours after an myocardial perfusion scintigraphy, and what they found that also in patients with mild and severe, moderate to severe defects, which were reversible, these markers increased 2 to 4 hours after the examination. So if we now look on the markers we have, first of all, we have, of course, have the troponins for the muscle necrosis. Then we have the natriuretic peptides. And in this respect, it's of interest that myocardial ischemia itself stimulates the increase of natriuretic peptides. But of course, the majority of release is triggered by the ventricular dysfunction mediated by ischemia. And of course, if we want to go a step previous, looking on ischemia, perhaps this ultrasensitive troponin assays may be a solution. because a lot of research efforts during recent years has been focused on identifying suitable candidates of myocardial ischemia markers. And if you go one step previous, on the events before ischemia occurs on plaque rupture. We have one marker which is available, which is high sensitivity C-reactive protein, but it's of course far from being perfect. So starting with these ultra-sensitive troponins, here again, data from the TIMI study group, they looked on their database of the TIMI 36 study, and they used such an ultrasensitive assay. And first of all, they looked on the patients which were negative with a standard assay, and they found in this population with a normal standard troponin a gradient of risk with these new assay concentrations. But please be aware, these are all patients with established acute coronary syndromes. And then they also looked on these troponins values in patients with had a normal troponin, ultrasensitive troponin concentration. And again, what they found is also in this normal range a gradient of risk in acute coronary syndromes. So there is something going on, and what we already know from work which is, has been performed a couple of years ago, if we combine markers, for example, troponin and high-sensitivity C-reactive protein, this adds in risk stratification in acute coronary syndromes, and this is also true according to more recent data for the high-sensitivity troponin T if you combine it with the high-sensitivity C-reactive protein. We also know that natriuretic peptides can be used for risk stratification in all aspects of acute coronary syndromes. And we also know if you combine markers picking up different aspects of acute coronary syndrome, this makes sense. This adds in the risk stratification in these patients. And this is also true if you combine it with the high-sensitivity troponin values. So based on this, what we already have, we have a really good data for using troponins and the other markers which have already made the way from research to clinical routine. First of all, with the troponin increase, we pick up the acute risk, the short-term risk mediated by the intracoronary thrombosis formation. We know what to do with these patients. We have to optimize management and antithrombotic and antiplatelet treatment. We also have good evidence for using high-sensitivity C-reactive protein for optimization of secondary prevention in patients after an acute coronary syndromes. What we do not have at the moment is data showing how to specifically react on the risk mediated by an increased natriuretic peptide value. These studies are still lacking. But of course, now looking on this, it's very difficult for any new marker to significantly add new information on this established marker panel. And now let's have this the pathophysiology. This has already been covered in a much more brilliant way. But once again, biomarkers are easy to measure if you find a marker which is suitable for routine use, which is stable without different and difficult pre-analytical phase. It would be an ideal candidate to pick up patients with vulnerable plaques. It would be also very suitable to identify patients with intracoronary thrombosis formation. But as you will see later on, the only marker which is really established is C-reactive protein. A lot of markers have been tested and compared. I will show you some examples, but none was substantially better than high-sensitivity C-reactive protein for this purpose. If you have a formation of an intracoronary thrombus, you have endothelial dysfunction, which can be also tried to pick it up with some biomarkers. On the other hand, you also have distal embolization of this plaque and thrombus material, which leads to sometimes only microscopic necrosis without ST segment changes. And again, a number of markers have been tested. None of them really made the way from research to routine yet. Again, I already mentioned natriuretic peptides. And then there is the field of markers of myocardial ischemia. One of them is ischemia-modified albumin. I will show you some data on it. This is the phase before myocardial infarction develops. And then, of course, as soon as necrosis occurs, we also have a systemic inflammatory response, which can be picked up again by the inflammatory markers. So just two examples from markers, which initially every marker led to enthusiasm, disappointment, and unfortunately only a few made it to routine use. For example, let's talk about this lipoprotein phospholipase A2 marker, which has been in the United States cleared by the FDA for risk stratification in coronary artery disease. There are two different methods available, one measuring the enzyme activity, the other just measuring by an immunoassay the concentration without considering the activity of that, what is really measured. Both are cleared by the FDA. This is a marker. This enzyme is produced by the endothelial cell. It's also released in the circulation as a soluble form, where you can find it in association with the lipoproteins. In fact, we also have some data for risk stratification in acute coronary syndrome, but nothing convincing, no convincing benefit over high sensitivity C-reactive protein. Another marker would be, for example, choline. A couple of years ago, it was very popular to look on choline. Choline is formed by the activation of macrophages, monocytes, but also within platelets when they are activated. A small proportion is also released in the plasma and can be measured there, but the main thing is to measure choline within the cells, and this, of course, is a little bit of complex analytics, and therefore it didn't make the way to routine so far. Then also matrix metalloproteinases, a lot of them were tested to identify patients with vulnerable plaques, but so far, unfortunately, no breakthrough at the moment. A similar fate, myeloperoxidase. There were several years ago, there was a pilot study, a pioneer study published in New England Journal of Medicine, where it could be shown that this marker is used for risk stratification in chest pain patients without troponin increase. Based on the study, a company went into the field and developed an assay which is suitable for routine use. Unfortunately, these promising results couldn't be, let's say, confirmed later on, and now we have an assay, but it's not used, actually, at least in Europe. Now, coming to myocardial ischemia. Here, one very promising marker was the so-called ischemia-modified albumin. Here, I'm just showing you the proof of principle study. Patients undergoing BTCA, these were only patients with BTCA, not stent implantation. Here, see this marker increases after the procedure quite rapidly and then goes down within a couple of hours. So in fact, this marker is released. So what's the biochemistry behind it? Albumin has the capacity to bind metals, and this is done in the N-terminal part of the molecule. And if albumin comes into contact with ischemic tissue, this N-terminal part is damaged and cannot bind as much metals as a normal albumin. And this was used to build up a colorimetric assay. Unfortunately, it turned out that the pre-analytical is not as simple as was thought, and also the analytical has some disadvantages. So the assay which has been approved was finally withdrawn from the market again. So now switching completely to another pathophysiological concept, copeptine testing. Copeptine is very popular at the moment, and there's a lot of marketing and pressure on physicians to measure copeptine in the emergency department. Well, the concept is following in situations where we have stress. It's completely unspecific. It may be stroke, sepsis, or also acute myocardial infarction. This vasopressin is released, and the actions, as you know, are sodium and water retention and vasoconstriction. The problem now is with vasopressin testing. If you try to measure it itself, it's very unstable, not really suitable for routine use. But as many other hormones, it's synthesized as the pre-pro hormone, and the N-terminal part, copeptin, is much more stable and more suitable for routine testing. So again, the proof of principle study showing if we induce in patients with obstructive hypertrophic cardiomyopathy, a myocardial infarction by the TASH procedure, you see copeptin quite rapidly increases and goes down. This is a disadvantage, also quite rapidly again. So in fact, we have a trigger. And if you use this marker together with a standard troponin assay, it appears, particularly in the early hours, that this marker adds something to the early diagnosis of acute coronary syndromes. You cannot use the marker itself because, as you see, the specificity is far too low to be of any value. You always have to combine it with the specific marker, and this is troponin. So based on this promising data, really one of the studies we really like to see in the field is an intervention trial was designed by a German group. They formed two groups, a control group with standard care, another group with copeptin testing. The only problem with the study is that the troponin was not measured in a core lab, so we had quite different troponin assays. We have 4 centers with high sensitivity troponin, others with a quite insensitive point of care, and others with a standard troponin assay. So that's really a problem for the interpretation of these results. In this study setting, it could be shown if you combine both markers, it's safe to release patients early from the emergency department compared to the standard care. And the problem again, all patients were followed carefully in the study protocol. So if you go to the routine practice, it's not easy to transfer these results because you have to fix the workup of the patients at the time of discharge. If you cannot do this, it's not safe to discharge them. But you can also identify low risk or very low risk patients easily if you use a high sensitivity troponin assay. Here, data from the troponin T assay. If the values are below the detection limit of the assay, these patients have a very low risk. So, and a very high negative predictive value. And in a sub-analysis of the SPEAK-8 trial, where just the patients with the high sensitivity troponin T testing were analyzed, the group with the lowest risk were the one at the bottom with the high sensitivity troponin below 5, followed by the other groups. So in fact, combining copeptin with high sensitivity troponin is not of that great advantage. And this, I just picked up one recent study that really looked on the patient population we are interested. These are patients with suspected coronary syndromes coming to the emergency department. They tested a lot of markers for risk stratification and diagnosis. Also some other markers, for example, not only copeptin as listed here, but also placental growth factor or another inflammatory marker, FSM like tyrosine kinase 1. Natriuretic peptides, quite a lot of markers. And first of all, just focus on the risk model, the clinical risk model, which is shown here. And the only marker which really added to this model for risk prediction was high sensitivity troponin T testing. All the other markers couldn't add to this panel. Now, some disappointing information on proteomics. Now, let's go to molecular biology. And you already heard this morning on the significance of these non-coding messenger RNAs. One of them are the microRNAs, and they are very popular at the moment. And what actually are these molecules after translation? Not every messenger, not every RNA really leads to proteins. The only messenger RNA is transcribed at the ribosomes into proteins. And what now these microRNAs do, they destabilize other messenger RNAs, and thereby they regulate the protein synthesis at this level. And interestingly, also these microRNAs are released and can be measured in the blood, which is really a little bit strange. Nobody knows what they are doing there, but we can detect them. And of course, all aspects of acute coronary syndromes have been also investigated with microRNA testing. This is the aspect of diagnosis, of risk prediction, and also platelet activation, which was also mentioned already today. Now, if we look on microRNAs, the most promising were the 208 and 499 because they are muscle specific and they were tested in the whole spectrum of acute coronary syndromes. And now coming to the first clinical studies, in fact, they are increased compared to controls in the non-STEMI and STEMI population. These are rather small studies at the moment. Now, if you look and compare them with high sensitivity troponin T testing, it looks a little bit disappointing. First of all, the microRNA 499 appears to be much better than the 208. But if you combine troponin T with these microRNAs, unfortunately, no significant benefit. The other problem at the moment is microRNA analysis is time-consuming at the moment and therefore not suitable for let's say, rapid testing. So, but what is also a topic and focus of research at the moment, perhaps it's possible to find a pattern of microRNAs which is suitable for differentiating unstable angina from necrosis, but at the moment we are not there yet. So if I want to summarize what we can conclude from the current data is, particularly in the area of these high sensitivity troponin assays, so far the novel biomarkers are not a story of success so far. They have a high negative predictive value, high negative likelihood ratios, but it's not 100% on admission, and that is what we would have at best. The major problem is lack of acute coronary syndrome and cardiac specificity. That's really a matter of concern. And most of these new markers are not sufficiently compared with the high sensitivity troponin assays. And there's also some enthusiasm at the beginning on the new kid on the block, and later on there is a realistic view on the markers. And yeah, at the moment I don't see a breakthrough on the horizon. Thank you.
Very interesting. Thank you very much, Jans. Our time is up, really, but I might allow only for one comment.
One comment. It's a great presentation. Thank you. But I see a lot of young people there and people working in emergency departments, and I think all these tests of troponin, high sensitivity troponin, roll in, roll out, 1 hour, 3 hours, are excellent tools for supporting the diagnosis. But we have to resist the temptation of being converted into the ticket checker in the movie theater entrance, and the patient you come in, you can out because you review the ticket of the troponin, because it's easier than to make clinical adjustments. It's easier than to do a good interpretation of the EKG. It's important because all of you are professors, me are as well in my hospital, and the young people may have the temptation of doing like this. They apply the troponin test and you have some value, you are in, and if not, you are out. And Dr. Kastrati have shown very well that the prone diagnosis is not easy in ACS. And the summary was very excellent as well because recognized the limitations. But the risk is this, I think. The young cardiologist is young, not cardiologist, because many people in the emergency department is not cardiologists and they are dealing patients with chest pain. Maybe have the temptation of doing this. If you have troponin positive, you are in, you're not, you are out. Please go out. Clinical adjustment and EKG demand more skills and more training and experience. That's my comment.
Yeah, I can only agree.
Thank you to all of you for attention. Thank you, all the speakers.